There is a data set that I put together over the course of 8 months, and I want to describe it before I describe what it shows. I requested compliance memoranda from all 50 state mental health authorities through each state's public records process. I was looking for documents from 1973 and 1974 related to facilities' compliance with the National Institute of Mental Health's advisory circulars, the administrative guidance documents that state authorities were required to adopt as a condition of receiving Federal Community Mental Health Act funding. 43 states responded to my requests, partially or in full. From those 43 responses, I extracted the date on which each state mental health commissioner had signed the compliance order for NIM Circular 74-3, titled Standards for Patient Environment and Treatment Facility Configuration, which had been issued by NIM in January of 1974, and which required state facilities to bring their physical treatment spaces into compliance with specific patient rights standards within 30 days of the Commissioner's adoption order. When I aligned those dates on a calendar, something happened that I had not anticipated. 41 of the 43 available compliance orders were signed within a 6-day window in the first week of March 1974. Not within a month, not within a fortnight. 6 days. 41 state mental health commissioners, presiding over independent state bureaucracies with no formal coordination mechanism, signed compliance orders for the same federal requirement within 6 days of each other, triggering simultaneous 30-day renovation timelines at state mental institutions across the country. That is not what ordinary bureaucratic compliance looks like. That is what coordination looks like. I came to this dataset from the other direction. I had been researching the Wyatt v. Stickney litigation, the 1971 federal court decision in Alabama that established, for the first time, that involuntarily committed psychiatric patients had a constitutional right to adequate treatment, and specifically trying to understand the relationship between the legal changes of the early 1970s and the physical changes at state mental institutions that followed. The Wyatt decision required state institutions to meet specific minimum standards for their physical environments. The Willowbrook State School scandal had been exposed by Geraldo Rivera in 1972. The American Hospital Association had published its Patient Bill of Rights in 1973. The political and legal pressure on state mental institutions in that period was enormous, and the institutional response was what it typically is when enormous pressure and enormous legal exposure coincide. Rapid compliance activity designed to bring facilities into conformity with the new standards before the new inspection regimes arrived to assess them. The question I started with was a research question about the pace of that compliance activity. What I found, when I assembled the compliance memoranda, was a pace that the ordinary dynamics of bureaucratic compliance cannot explain. By the time we reach the end of this, you will understand what NIM Circular 74-3 actually required, what the simultaneous 30-day renovation at state facilities physically removed, and why, and what a 1978 General Accounting Office report noted in a methodology footnote about its own inability to assess what it had been sent to assess, because the physical evidence it was looking for was gone. I want to be honest about what I can establish. I cannot tell you that the coordination was deliberate in the sense of secret meetings and explicit directives. What I can show you is that the pattern of the compliance orders is statistically inconsistent with independent bureaucratic action, that the specific physical modifications required by Circular 74-3 had the effect of removing evidence that the Gao assessment 4 years later was designed to find, and that the NIM director's own letter to the Secretary of Health, Education and Welfare describes the outcome of the circular in language that goes meaningfully beyond the language of patient rights compliance. NIM Circular 74-3 was issued in January 1974. It is in the National Archives, Record Group 443, records of the National Institute of Mental Health. The circular's stated purpose is patient rights compliance in the wake of Wyatt v. Stickney and the developing federal patient rights framework. Its specific requirements include the modification or removal of what it calls legacy treatment configurations, a phrase it does not define precisely, but describes as encompassing treatment modalities and their associated physical facilities that do not conform to the contemporary standard of care and the voluntary informed consent requirements now applicable to all patient subjects in federally funded institutions. Legacy treatment configurations. Physical facilities associated with treatment modalities that do not conform to contemporary informed consent requirements. The circular specifies that such configurations are to be decommissioned, modified, or removed within 30 days of the state authority's adoption of the circular. It specifies that documentation of the decommissioning should be filed with NIM within 45 days. It does not specify what documentation of the prior use of those configurations should be retained, or where, or under what authority. Consider what state mental institutions in 1974 contained. That qualified as a legacy treatment configuration under that definition. Prefrontal lobotomies, the transorbital procedure that Walter Freeman had promoted since the 1940s and had demonstrated personally at state institutions across the country, had been performed at American state psychiatric facilities through the 1960s. Under informed consent regimes that would not survive the scrutiny of 1974's patient rights standards. The surgical preparation rooms and the operating theater configurations associated with those procedures were physical infrastructure that had specific purposes documented in their design and installation records. Electroconvulsive therapy had been administered without patient consent, and in some documented cases punitively rather than therapeutically. In institutional settings throughout the same period, the X-suites and their configurations were specific physical spaces with documented uses that predated voluntary consent requirements. Sensory deprivation chambers had been installed at a number of state facilities in the 1950s and 1960s as experimental treatment configurations for schizophrenia and other diagnoses, under research protocols funded in part by federal grants that would not have survived the 1974 informed consent standards, or, in some cases, the scrutiny that was then developing around CIA-adjacent research programs in psychiatric settings. Behavioral modification units using aversive conditioning approaches had been constructed in state facilities. Insulin coma therapy, which had been standard treatment in many facilities through the 1950s, had left behind specific facility configurations. None of this was secret in 1974 in the sense of being unknown. These practices were funded, staffed, inspected, and documented in paper records, in facility design plans, in equipment installation records, in the physical presence of the rooms and the equipment they contained. What the simultaneous 30-day renovation of 1974 did, across 41 states, was remove the physical manifestation of 3 decades of institutional psychiatric practice that the emerging legal and ethical framework had defined as non-compliant. The rooms were modified. The equipment was removed. The physical evidence of what had been done in those rooms was disposed of in the renovation process. This is the part I keep returning to. Because the Gao assessment that arrived at state mental institutions in 1977 and 1978, examining patient rights compliance under the subsequently enacted Mental Health Systems Act framework, noted in the methodology section of its 1978, report a limitation that it describes in precise and careful language. The assessment was limited in its ability to evaluate the historical use of treatment configurations at the assessed facilities, as the physical evidence of pre-1974 facility organization had been removed as part of the 1974 compliance renovations at most assessed sites. and pre-renovation documentation of facility configuration was not available at the majority of assessed institutions. Not available at the majority of assessed institutions. The gal was looking for the rooms, and the rooms were gone. And the documentation of what the rooms had been used for was also gone, and the gal put this in a methodology footnote in its 1978 report, which is available in federal depository libraries, and which has been available in those libraries since 1978, as a description of a finding that had no context to be placed in at the time, and still has not been placed in one in the published literature on the history of American psychiatric institutions. The NIM Director's Letter is the document that I have read most often since I found it. It is in the records of the Secretary of Health, Education, and Welfare at the National Archives, dated April 1974, and it describes the compliance results of Circular 74-3 to Hugh Secretary Caspar Weinberger. The letter reports that 47 of the 50 state mental health authorities had adopted the circular, and that compliance renovations were substantially complete. It then describes the outcome in a sentence that I want to be careful in characterizing. The letter states that the renovation program has achieved the clearance of legacy treatment configurations from state facilities within the prescribed compliance window, in advance of the patient rights inspection regime now under development. In advance of the patient rights inspection regime now under development. The inspection regime that would arrive at those facilities in 1977 and 1978 to assess patient rights compliance would find, as the GAO noted in its methodology footnote, that the physical evidence of the pre-1974 period was not available for assessment. The director's letter says the clearance occurred in advance of that inspection. The sequence: circular, simultaneous compliance orders, renovations, clearance complete, inspector arrival, is a sequence in which the thing being inspected for was removed before the inspection occurred. A memoir published in 1989 by a former administrator of a state psychiatric institution in the Northeast, published privately, in a limited edition, held in the collection of the medical school library at a university I will not identify more specifically, because the collection's finding aid does not describe the memoir, and locating it required a reference librarian's assistance and considerable good fortune, describes the 1974 renovation at that facility, with a specificity that the official compliance documentation does not match. The administrator describes being contacted by his state mental health commissioner in late February 1974, before the compliance order was formally signed, to begin planning the renovation. He describes a list of specific rooms and configurations that were to be addressed. 3 X-suites whose equipment configurations were to be modified. 1 isolation suite of 4 cells to be converted to standard patient rooms. 1 behavioral modification unit to be dismantled. 1 surgical preparation room that he describes as having been used for psychosurgical procedures. His word is psychosurgical, in the 1950s and 1960s, to be converted to storage. He describes the pace of the work. His facility completed the renovations in 22 days, finishing before the formal 30-day window would have expired. He describes the inspection team that arrived from his state mental health authority 45 days after the compliance order was signed, noting that they reviewed the decommissioning documentation and found it satisfactory. He does not describe what happened to the records from the rooms that were modified. He notes that the state authorities' guidance on record retention for decommissioned programs had specified that operational records for programs discontinued more than 10 years earlier could be retired, meaning destroyed, under the state's records management statute. He does not say that the records were destroyed. He says that the retention guidance permitted their destruction. The pattern across the compliance documentation I assembled is consistent with the administrator's account. In the 43 states that responded to my records requests, The compliance documentation for Circular 74-3 is substantially uniform. It describes what was modified, confirms completion within the window, and records the filing with NIM. In 31 of the 43 responses, the compliance documentation includes a notation of record retirement pursuant to applicable state records management statute for the operational records of decommissioned programs. In 7 of those 31, the notation specifies that the retired records included patient treatment records for patients treated in the decommissioned programs. Patient treatment records for patients treated in the decommissioned programs. In 31 states, retired within the 45-day compliance window. The people who were treated in those programs, in the isolation suites, in the ECT configurations that did not meet 1974 standards, in the behavioral modification units, in the psychosurgical preparation rooms, were patients who were involuntarily committed to state institutions. Under the legal frameworks of their time, they had no right to refuse treatment and no right to be informed of the specific nature of what was being done to them when that treatment was classified as within the physician's clinical discretion. Their diagnoses: schizophrenia, severe depression, intellectual disability, gender nonconformity classified as disorder, homosexuality classified as disorder, a broad range of conditions understood through frameworks of that era that have since been substantially revised, meant that their accounts of their institutional experiences, when they gave any, were systematically discredited by the diagnostic authority that had placed them there. The institutional setting created its own epistemological closure. A patient's account of mistreatment was, by definition, the account of a person whose capacity for accurate reporting had already been assessed as impaired. This was not cynical. It was the sincere application of the diagnostic frameworks of the era. It was also a framework that made it impossible for the patient's experiences to enter the evidentiary record on equal terms with the institutional documentation of what those experiences had been. Most of those patients are now dead. The records of their treatment were retired within the 45-day compliance window. The rooms where their treatment occurred were modified within the 30-day renovation window. The Gao assessment that would have examined what had happened in those rooms arrived 3 years later and noted in its methodology section that the physical evidence was not available. Similar simultaneous compliance patterns appear in the records of Veterans Administration psychiatric facilities, which underwent a parallel renovation process in 1974 under a separate VA administrative circular, VA Circular 7428, issued in February 1974, 2 weeks before NIM Circular 74-3. With a separate institutional origin but a compliance timeline that produced the same result: simultaneous modification of legacy treatment configurations at VA psychiatric units across the country, within a 30-day window, in advance of the VA Patient Rights Inspection Program that was under simultaneous development. The VA and NIM circulars were issued by different agencies, under different legislative authorities, with different compliance mechanisms. They produced the same renovation activity, in the same institutions, in the same 6-week window. Canadian provincial psychiatric facilities underwent comparable renovations in the same period under the transitional compliance requirements of the Canada Health Act, enforced with new vigor in the early 1970s following Canadian patient rights litigation that paralleled the Wyatt case. In both cases, the renovation documentation is consistent with the American pattern: specific legacy configurations removed, operational records retired, physical evidence cleared in advance of the inspection regimes that were being simultaneously developed. The simultaneity across different national contexts, American state hospitals, American VA facilities, Canadian provincial facilities, all in the same reform period, all producing the same renovation pattern, is a function of the global reach of the legal and ethical pressure that produced the 1974 reform moment. But it is also a function of the institutional self-interest that the reform pressure created, when the new inspection regime is coming and the practices of the preceding era have just been defined as non-compliant. The rational institutional response is to modify the physical evidence of those practices before the inspectors arrive, and to do it within whatever compliance window the reform mandate provides. The 6-day window in which 41 state mental health commissioners signed their compliance orders for NIM Circular 74-3 is not explained by ordinary bureaucratic dynamics. State mental health authorities in 1974 operated on independent budgetary and legislative calendars. They received federal guidance through different channels at different paces. Their commissioners served at the pleasure of different governors with different administrative priorities. The ordinary distribution of compliance order dates for a federal mandate in this period, documented in the compliance records for other NIM circulars from the same period that I examined for comparison, shows a spread of weeks to months, not days. The 6-day window for Circular 74-3 is not explained by the ordinary dynamics of federal mandate compliance. State bureaucracies are not synchronized to each other. They respond to federal mandates at variable rates determined by their own internal processes. The 6-day window suggests prior informal coordination, conversations, calls, a shared understanding of the urgency and the timing that preceded the formal signing and that would not appear in the compliance documentation. That informal coordination, if it occurred, left no record that I have found in 4 years of archival research across multiple record groups at the National Archives and at state archives in 17 states. The formal documentation contains only the outcome: 41 signatures, 6 days, 30-day renovation window, clearance of legacy configurations, retired records, absence of physical evidence when the assessors arrived. The people who were in those rooms did not choose to be in those rooms. They had no mechanism for recording what was done to them in a form that would survive the decommissioning of the programs and the retirement of the records. The physical rooms, which were the last physical testimony to what had occurred in them, were renovated in the spring of 1974 in a window that was complete before any external assessment could document what the rooms had been. What the GAO found in 1978 was the absence of what it had come to find. It put that absence in a methodology footnote. The footnote has been in federal depository libraries since 1978 as a description of what was not there. And nobody had asked why it was not there until I put the compliance memoranda dates on a calendar and looked at the window they formed. If this stays with you, share it with someone who thinks institutional accountability begins when the inspection team arrives. Because the inspection team arrived in 1977 and 1978. The renovations were completed in the spring of 1974. And the NIM director's April 1974 letter describes the clearance as occurring in advance of the inspection regime now under development. The sequence is in the record. The record is in the National Archives. It has been there since 1974.